Hi everyone, welcome back to Friday's RLR episode. Um, my name is Jazz. I am the case presenter, but I actually have two special guests, which I'll get into in a second.
Jazz,
I am actually been,
we're not that special, Jazz. We've been here every Friday.
yeah, thanks, thanks,
Oh,
Reza.
baby.
You couldn't help yourself to just not interject. But I'm actually been banned to present cases to RLR. But the one way I can kind of like get around that is to have my residents present. And I think it's going to be a great case. I think this is a case that we learned a lot from, and I feel like it's will bring a lot of teaching points to everyone here. Rabih and Reza, not to put any pressure on you, I've worked with 7 IM residents at RGH, and you guys are 0 for 7 in terms of they didn't know what the clinical problem solvers were. So I expect you both to put on such a great show that Akriti and Ali go back to RGH and says, hey, we all need to like tune into CP solvers. So no pressure. With that being
Yes,
said, I'll
my
turn it.
turn to interrupt you and tell you that RGH will soon be known as RRGH after this.
For that, I'm going to turn it over to Ali first, and then Akriti to introduce themselves. Guys, if you want to just say hello, and then what you like to do outside of medicine.
Hi everyone. I'm gonna start first. So my name is Ali Mohammed. I'm a third year resident at RGH, internal medicine. Outside of medicine, I enjoy hiking, biking, some other outdoor activities. I also used to, I shouldn't say used to. I mean, I enjoy playing piano. I'm not doing as much as I should, but I'm trying to keep up and learn more about piano. So yeah, thank you for having me here, and I'll let Akriti introduce herself as well.
Hello, everyone. My name is Akriti. I'm originally from India. I'm a second-year resident at RGH. Outside of medicine, I like to draw, mostly digital drawing because I like anime and stuff, so that's what I draw mainly. And I also like dancing. I'm an Indian classical dancer, but I haven't been doing that much since I came here.
Well, guys, we're so excited to have you. Thank you so much for joining us. And yeah, I am excited that this might be your first introduction to CP solvers. It's my favorite hour of the week when I get to hang out with Prof. Rez and have guests like yourself share their love for medicine and their cases. So whenever you're ready, we'll kick it off and have a lot of fun together.
All right, I can start. So our case here today is basically an 88-year-old female who was sent from the cardiology office for evaluation of hypoxia. So she initially presented to the cardiology office with a complaint of exertional shortness of breath and chest tightness. She was found to have SPO2 of 89%, and that's why she was sent to the emergency department. So when seeing her in the ED, she reported that for the past 4 to 6 weeks, she has been having progressively worsening exertional shortness of breath and chest tightness. She usually takes 7 or 8 steps before feeling out of breath and needing to take some rest. The chest discomfort was substernal and it was radiating to the back bilaterally, and again improves with rest. She also reported some lightheadedness and a pre-syncopal episode, but not syncope. So when she is exerting herself, walking her dogs out, she started feeling some dizzy spells and about to lose consciousness, but never lost consciousness. Regarding her other symptoms, she reported a dry cough. There is no sputum production. There is no hemoptysis, and also denies any fever, chills, flu-like symptoms, or any kind of upper respiratory tract symptoms. She does not have any symptoms at rest. She's not having chest pain or shortness of breath while at rest. And also she denies any GI symptoms, including nausea, vomiting, abdominal pain. The only symptom she had was decreased appetite and weight loss. So she hasn't been eating as much as she used to. And in fact, she lost about 20 pounds over the last year. Regarding other symptoms, she does not have leg swelling, she does not have leg pain, and she also denied any recent travel history or recent surgeries. Moving on, so apart from the weight loss, when asked about night symptoms, she denied any fever at night, sweating at night. She denies, she does not feel any bumps or swelling in her neck or other lumps in her groin or the axilla. And there was no rash as well. So this is pretty much her presenting complaint. I can go to the next part whenever.
Ali, this is great. I think it's a great place to stop. You gave us a lot of rich data to interpret. By the way, my brother's name is Ali. So I'm already liking you, and I don't even know you.
Oh, thank you. Thank you so much.
And maybe what I'll do is just share some general thoughts, but I think this aliquot is so rich, Rabih, that I would really love your input as well. And I'll say this, that like the most striking thing is the hypoxemia. You see, shortness of breath is a subjective concern that a patient presents with, while hypoxemia is an objective finding. And the best way to think about hypoxemia is to think that there's an issue at the alveolar capillary level. And so there's an issue at the alveolar capillary level, though you can have hypoxemia in someone who's on a lot of opiates or is sleeping and has OSA, and they're just not breathing much. But usually it's because of an elevation in the AA gradient. So with that in mind, then we can use other parts of the story to see where the pathology is that has led to a difficulty in oxygen getting into the capillary, in that alveolar capillary connection. And we already know that this patient's at a cardiology clinic, so likely has a past medical history of cardiac disorder, but two organs become the primary culprit of hypoxemia, and that's the heart or the lung. And that's assuming there's actual abnormalities that we see on exam or we see on imaging. So it's going to be really important to examine the JVP. It's going to be critical to examine the lungs. And with the exam, the chest x-ray, the B Nancy peptide, we'll be able to make progress. But already there should be a high pretest that something's happening in the heart, not only in the heart, but the left side of the heart that may be congesting the lung. But that's not the entire story, because if this was just your typical congestive heart failure, why are they losing weight? Usually people with heart failure are volume overloaded and they gain weight, which takes us to another unusual feature of this case, which is the weight loss and the timing of that weight loss. It's telling you that this problem isn't happening yesterday. Maybe this part of the shortness of breath and the hypoxia is more recent in onset, but it's really giving you a flavor that something has been going on for some time in this patient. I'll actually, leave it at that and pass the mic to Rabih to add more on the other things and talk about the weight loss as well.
Well, Prof. I don't think there's anything to add, quite honestly. I think that the story is very suggestive of cardiac issues, and the most common cause of a cardiac issue plus hypoxemia as congestive heart failure. But I think you're teaching us all the unusual things. And so the question is this just an unusual form of heart failure, or is this something that looks and smells like heart failure, but is fundamentally different? And I think that's the tension that I'm living in right now. And I do think that the weight loss is so unusual that it deserves a strong scrutiny. I would just say, to comment briefly on the chest pain, that this story is very, very suggestive of angina when somebody has exertional chest pain that resolves with rest. And if you just focus on that and delete everything else, you would immediately start to think, oh, this person is having coronary artery disease. And that is actually very, very possible, even if there are some unusual features because of all the complications of coronary artery disease. So you can easily paint a picture, for example, that this patient has CAD, has had chronic ischemic cardiomyopathy or an MI, and that's why that she's in heart failure. But I will say there are two very atypical features here. And the atypical features are that the patient has a presyncope or syncope with CAD. Presyncope or syncope with coronary artery disease is an extremely rare finding, and a finding evocative of severe advanced disease. So much so that when the patient walks, her EF drops, and therefore she gets a hypotensive response. This phenomenon has a stress test equivalent. Most of us get hypertensive when we exercise to perfuse our organs. And if this patient is getting hypotensive with exertion as a manifestation of CAD, it by definition stratifies her as having extensive disease. So either this patient either the story is not compatible with coronary artery disease, and either is a CAD plus a complication, or extensive CAD, or not CAD at all if we link in the presyncope and, of course, make the observation that the hypoxemia is out of proportion to heart failure and suggests another cause. So I would just caution people when they get a presyncope component to an anginal story, it means one of three things. It's not CAD. It's another mimicker of CAD, like pulmonary hypertension. It's CAD with an extensive complication like heart failure, or extensive CAD without heart failure, but really bad triple vessel disease. So I'm really excited to see what that pans out, because it certainly struck me. All right, we'll hand the mic to you all for round two.
All right. Thank you for this fruitful discussion. So moving on to the past medical history, she does have a history of AV block, status post permanent pacemaker placement 10 years ago. She also has NSVTs, following up with cardiology. She has hypertension, hyperlipidemia. She also had carotid endarterectomy for carotid stenosis a couple of years back, along with COPD, GERD, and osteoporosis. Moving on to her home meds. So she takes vitamin D and calcium supplements for her osteoporosis. She's also on Toprol XL 100 milligram BID for her NSVT. She's on Lipitor 40 milligrams, amlodipine 2.5 milligram, along with hydrochlorothiazide 25 milligram, and she's also on omeprazole 20 milligram. So moving on to the family history. So she does report her maternal aunt has died of a cancer, not sure which type of cancer. When asked about other family history of cancer, she denied any, and also denied autoimmune disease, including sarcoidosis and myasthenia gravis. So social history, she did mention that she traveled by air to North Carolina a few months back, not recent. I think it was 4 months ago. She lives with her son and his family, and also has 4 dogs. She's active at baseline and pretty independent in her ADLs. Moving on to her behaviors. So she used to be a smoker for quite a long time. She quit smoking 22 years ago, and she has a history of more than 40 pack year smoking in the past. Alcohol, she reported drinking 1 glass of wine every day. And upon further questioning, she did mention that she cut down on alcohol. And when asked if she was, if this is due to intolerance, she did not feel like she was not tolerating this. She didn't have nausea or hot flashes with alcohol, but just don't feel like she want to drink her usual glass of wine. For allergies, she does have, she is allergic to gadolinium contrast, but no other allergies. I don't know if I mentioned this, but the pacemaker was placed 10 years ago. I can go on and continue to the exam findings, or if you want to ask any
Ali, I think we can pause here to see if Reza and Rabih want to say something.
Yeah, thanks, guys. I would just say that the thing that struck me is this is not a blank slate. And there are so many comorbidities that can compound and explain this syndrome. And I think it would be a very different scenario if this patient had no medical history and were younger, where the range of possibilities would be infinitely wide. But what happens now in real life, and it should happen here too, is you now can invoke many explanations to the existing conditions that she has without need to invoke many other things. So the hypoxemia may be due to advanced COPD, the anginal chest pain may be to the fact that she's had carotid artery disease and now has coronary artery disease. She may develop progressive heart dysfunction as a result of ischemia or as a result of age-related conduction system disease. So I think now you would probably examine the patient and study the fingerprint on her body. And the first step is to try to connect it to something she already has as a parsimonious explanation. And that's probably what I would be doing. It would take a lot of extra work to deviate beyond the simple explanations right now. And those simple explanations would be CAD, heart failure, and COPD contributing to a multifactorial picture. It leaves the weight loss unexplained. However, weight loss is commonly explained by these conditions being advanced and severe, causing advanced thoracic dysfunction, and the overall cachexia and severity of this syndrome causes the patient to ultimately have COPD-related cachexia and cardiac cachexia. So those would be your working hypotheses. But you have to remain vigilant that just because the patient has these conditions doesn't mean they're the root of the current problem today. By the way, I stopped listening after you said she had 4 dogs because this must be the best patient ever. Good on her.
Yeah, right.
Thoughts, Reza?
What's that?
Oh no, I was just asking Reza if he had anything to add.
Dude, I swear listening to you is like poetry, man. This parsimonious, the signature, the under. I'm glad it's being recorded.
You know, I study my SAT vocabulary right before RLR, so
I bet you do.
I'm glad it works out. All right, guys, we're ready for the next round of information, whenever you are.
All right, let's get her vitals. So her temperature was 36 degrees Celsius or 96.8. Her heart rate was 78 beats per minute, and blood pressure was 124/55. Her respiratory rate was 18, and she was maintaining 90% saturation on 2 liters nasal cannula. Her BMI was 21 as well. Rest of exam, so general look, she didn't look in acute distress. She didn't have any cervical or axillary lymph nodes. Her heart exam was essentially normal heart sounds, normal pulses. There was crackles in the right upper loop and the left lower loop on exam, no wheezing or other added sounds. The abdomen was soft with no palpable masses or tenderness. She was oriented to time, place, and person, and extremities. She did not have leg swelling, but there was erythema along with swelling and increased warmth in the left antecubital fossa. So this patient was seen after she got the CAT scan with contrast, and the patient was thinking this might be due to the contrast, the thing in her left antecubital fossa, which was the site of the IV. Moving on to initial labs. So her CBC showed normal WBC 7.2 with normal differential. Hemoglobin was low at 11.7. MCV and MCH were within normal. And the platelets were down at 68,000. The last count of platelets was 200 1 year ago. So a drop, I don't know, maybe in a year or so. Moving on to the basic metabolic function. So she had a creatinine of 1.7 and BUN of 32. Her baseline was creatinine of 0.9 to 1.1. As well, the rest of electrolytes, so her calcium was up at 12.1 with a baseline of 8 to 9.5 in the past, and the rest of electrolytes were within normal. With these abnormal values, the hypercalcemia and the AKI, she was started on IV fluids and her labs trended nicely. Her creatinine dropped back to baseline and also her calcium corrected with IV fluids. Now I can pause for some time if you want to discuss any of these labs.
Ali, that sounds great. Can I ask you, how was her JVP?
Oh, yes. Sorry, I forgot that. So yeah, she didn't have GVD distension. Her GVD was essentially not distended.
I understand. And did her BMI, like you said it was 21, before, do you have a prior BMI or a weight?
So trending her weight, she did lose more than 10 pounds from the last six months ago, when her weight was checked in outpatient visit.
Perfect. Thank you, Ali. I'm going to leave the labs for Robbie to dissect. I will talk about the physical exam, and we'll get right to the vital signs. And one really important note is that if someone is hypoxemic, I'm not sure if that 89% was on room air or not, but if you give them oxygen and they don't improve, you really have to consider shunt physiology. It's just so important. There's very few things that when you give someone oxygen and you don't see a good improvement, you have to consider shunt physiology. I think the striking thing on physical exam, if we just go back to the first aliquot, we're trying to decide, is the lesion at the heart or is the lesion at the lung? And the cardiac exam, while limited, the lack of jugular venous distension, the lack of edema in the legs, it really lessens its likelihood. But I would still send a pro-BNP, which is much more sensitive at telling us if there's any kind of ventricular stretch or not. The crackles is telling you one of two things. Either there's a substance in the alveoli or there's atelectasis. The substance hypothesis would be fluid, pus, blood, protein, or cancer cells. And it's very, you can't go beyond that. You want imaging to see what these, what the crackles will correlate with. And we have a CT scan. We don't have the results yet, but I'll be very curious to what that CT shows. And in speaking about this erythema in the antecubital area, this patient told the physicians he had an allergic reaction to iodinated contrast. We don't know what that allergic reaction was. In fact, if it was something like anaphylaxis, they would have pre-medicated her with like Benadryl before giving the iodinated contrast. But if you think about it, this contrast agent, if it's causing a reaction, it's going in the blood, assuming it made its way into the blood. So the allergic reaction shouldn't be local, rather it should be systemic. You could have a local reaction if you don't inject the contrast actually into the vein. Like I once had a patient where we wanted to get a CT of the chest with IV contrast, and then the radiologist called us and like there was no contrast used. We're like, what are you talking about? We gave the contrast. They're like, go examine the patient. And then that whole arm was ballooned up because the contrast never made it into the vein. It was all in the subcutaneous tissue. So it's going to be really important on that CT scan to know, did the contrast actually make it into the vein or not? Because if it didn't, then I'd be most worried of contrast being in the subcutaneous tissue, which you have to monitor the patient for 24 hours because you can develop compartment syndrome from that process. The other simple thing could be, could she have like a thrombophlebitis that's developing from the IV that's placed? But that shouldn't really explain this year of weight loss and the chronicity of her symptoms. So with all of that, before I hand the mic to Rabih, just highlighting hypoxemia, we have signal in the lung, we're waiting for the imaging results. The antecubital swelling, we have to make sure contrast hasn't extravasated. But right now, there's no strong signal for the heart based on our physical exam.
Prof. Rez, that was absolutely awesome. I love the dissection of the, like trying to understand the syndrome better. How much was her weight loss? What's the significance of her hypoxemia? And just a very realistic analysis of what that erythema represents. And I was thinking about how to share my thinking on the labs. And it reminded me yesterday of when my patient came in and he had acute toe pain and he had podagra, classic gout. But he was actually in the triage room and he sneezed 3 or 4 times. And my ridiculous brain was like, is the sneezing a clue? And the answer is no, it's not a clue. It has nothing to do with what's going on. And I think I'm actually wondering that about the calcium, because the calcium may be utterly distracting in somebody who is on calcium supplements and who is on hydrochlorothiazide. The truth is that when calcium or hypercalcemia is part of a systemic syndrome, you really prioritize malignancy and granulomatous disease processes. And that's why when somebody gets admitted to the hospital, and hypercalcemia that requires hospital admission is often reflective of cancer and very, very rarely granulomatous disease. But this hypercalcemia may represent maybe just as my patient with gout sneezing, because the patient has something else going on and is either dehydrated and the effects of hydrochlorothiazide are kicking in, or she's using calcium supplements in some way, shape, or form to alleviate some of the suffering that's coming inevitably from this process. So I think it remains to be seen if the calcium is signal or noise. And certainly in the pretest probability of malignancy based on the weight loss, you should worry more about the calcium representing that. But I think when it washes away with fluids, as we were just told, you start to wonder again if it's the sniffles or if it's real. And I think that that is a question that remains to be answered, but will only be informed really when you get that workup of what the PTH is, what the PTHRP is, or as you start to understand the syndrome better. And I think one way we can understand the syndrome better is by studying the anemia and thrombocytopenia that this person has. And whenever you're thinking about anemia and thrombocytopenia, we should really take a pause to make sure that they're actually being caused by the same thing as you link them together. Because the truth is that the anemia may be anemia of chronic inflammation, which here is a very compatible hypothesis since the anemia doesn't seem to be as bad as the thrombocytopenia. And so to simplify the exercise in my mind, I think I'm inclined to talk about the problem not as anemia and thrombocytopenia, but to actually label it as mild anemia with disproportionate thrombocytopenia. And that's having me run the differential diagnosis of isolated thrombocytopenia simply to make practical progress. And whenever you're thinking about isolated thrombocytopenia, the lesion can be in one of 3 places. It's the platelets are being destroyed from the inside, usually from an infection. And we got some spaced learning on this in the CP Solvers Academy WhatsApp group yesterday, where Mukund shared some cases of malaria on the peripheral smear. It can be a problem on the platelet membrane, and that has to do with platelet antibodies. Some of them are named, like heparin-induced thrombocytopenia and antiphospholipid antibodies. but most of them are not. And that's the whole world of immune thrombocytopenia, where there are non-named antibodies that kill platelets. And then finally, not inside or on the membrane, but on the outside in the environment. And the environmental causes are the single most important one. And that includes the most morbid, which is a microangiopathic hemolytic anemia, which then makes us revisit the significance of the anemia here. And then finally, not the most morbid, Maha, but the most common would be splenomegaly. And so here, I think the practical next steps are to get a peripheral smear to give you a sense qualitatively and help you understand what quantitatively you are noticing now. And then to pursue cross-sectional imaging, maybe beyond the chest, which you would be inclined to do initially, and extend it into the abdomen to see if there is a occult footprint in the abdomen, either that explains the weight loss or that may explain the platelets in the form of splenomegaly. So long story short, I think it's hard to ignore the platelets and especially the anemia and the calcium may be profound clues as we make progress, or may be less important as they may wash away as anemia of mild inflammation and calcium from calcium intake. Cool. All right. Tell us more, please.
Sure. I'll be taking over the rest of the labs and imaging. So for the next set of labs, her troponins were negative. BNP was 312. Her inflammatory markers, ESR was normal at 12, but CRP was slightly elevated, 19.4. Because of the calcium, like we discussed, we did get a PTH, which was less than 6.3. And we got vitamin D levels, vitamin D 25 and 125 hydroxyvitamin D, which were both normal. And PTH-RP was also normal. Her ACE levels were also normal at 61 because we were checking for granulomatous conditions and sarcoid. Other than this, her D-dimer was quite elevated. It was more than 7,000 with normal coagulation parameters. She did have low iron of 26 with iron sats of 12 and a ferritin of 260. Folate and B12 were normal, but this is part of the anemia workup. HIV was negative, hepatitis panel was negative. Going on to her EKG, she did have a right bundle branch block with S waves in lead 1 and Q waves in lead 3. We did get an echo for her, which showed normal LV function and visually normal RV function with low normal RV systolic function. The CAT scan of her chest showed multiple acute pulmonary emboli bilaterally with no RV strain, and confluent mediastinal and bilar hilar lymphadenopathy, along with scattered ground glass opacity in the right upper lobe and the left lower lobe. Following this, she did get a venous Doppler ultrasound of all 4 limbs, which showed no DVT in the upper limbs, but there was a DVT within the right femoral and the right popliteal vein, and no DVT in the left leg. On the ultrasound, she did have a left axillary lymph node, about 1 centimeters. So I'm going to pause here before I move on to further investigations.
Balfraz, I babbled a lot. I'd love to hear what you're thinking.
Well, we always love you babbling, my friend. I think this is really this is our pivot point. So we have multiple pulmonary emboli, and this can certainly explain her feeling of lightheadedness. In fact, about 10% of patients with PE may present with syncope. It's important to realize that because acute PE can lead to acute pulmonary hypertension, which makes it difficult for the right side of the heart to get blood to the left side. And all of a sudden, if you don't have blood in the left side, guess what? You're not going to perfuse your brain as well. So you can feel lightheaded. And in looking at this echocardiogram, it is reassuring that the RV systolic function is normal. Because let's be practical here. When you diagnose a PE, there's a few important steps to take. One is you gotta risk stratify that PE. And many of you know this as like massive versus submassive, but the pulmonologists use the terms high risk, intermediate risk, or low risk. In high risk is in someone with hypotension and pulmonary embolus who's not responding to fluid. Those patients will all die unless you give them thrombolysis. Very high mortality. The intermediate risk is anyone who has any evidence of right ventricular strain. And so how can you tell if someone has evidence of right ventricular strain? You can look at their EKG and see if they have that classic S1Q1 T3 pattern. Sinus tachycardia can be a clue, right axis deviation. Enzymes are the most important, the troponin and the BNP. So it's going to be really important here. And agreed where the BNP was elevated and the troponin was normal, correct?
Yes.
So already I would put this patient in the intermediate risk category. The other way you can look for any evidence of RV strain is looking at the CT scan. You see the RV, the anterior structure should be smaller in size compared to the LV. So if they're equal in size on CT, that's RV strain. And then finally the echo, you can find some findings on echo. But in this, what I didn't mention was the size of the clot or the number of clot, because the radiographic finding of clots have no indication to what level you would put the patient at with PE. So I would say this is probably intermediate risk. Then the next question becomes, what's driving the PE? What's causing it? And I will tell you this, in most comers, it doesn't require any workup. They've done so many studies, and there's a great NAGEM article, meaning you just treat them for at least 3 months with an anticoagulant, preferably a DOAC. And then you decide at 3 months, should I continue or not? And that's based on whether they are having any side effects and such. But this patient has another finding, which means we can't stop at PE. And this is beyond the weight loss, and that's the lymphadenopathy. So now we have PE, and I can bet you that this PE, whatever is driving this hypercoagulable state, is also causing this lymphadenopathy. And now all of a sudden, you go back and revisit this calcium. And the interesting thing is that when someone has kidney injury, they actually immediately lose the ability to 1-alpha hydroxylate vitamin D25. So immediately in acute kidney injury, you might see some hypocalcemia. So maybe normal calcemia may not be so normal in someone with kidney disease. So I think maybe briefly, I'll just talk about the lymphadenopathy and then pass the mic to Robbie to incorporate everything else that we're seeing here. With the lymphadenopathy, the PE and the thrombocytopenia, it's hard not to think about DIC. And remember with DIC, we have this, you can have like a low fibrinogen. You might see schistocytes in half the cases on smear. And then you might ask, what's the common causes of DIC? Infection, but also cancer, malignancy. So then we revisit the lymphadenopathy, and lymphadenopathy, the way you can get at a diagnosis without biopsy is in a few scenarios. And that includes if someone has HIV, I would send an HIV test. The age doesn't dissuade me from that. Anyone can be sexually active. She has weight loss. She has lymphadenopathy. She has PE. I would send EBV and CMV. And then the other test, though it would be unlikely, it would be an ANA. But if this was a younger person, it would be a very good story for potentially lupus. ANA, also Sjogren can cause lymphadenopathy. But I think the real concern is this representing an underlying malignancy? And so to address that, it would either be, I would probably get a PET CT, to be honest, to see if anything lights up. Now, if you have that capability at the institution you're practicing. But I think it's important when you have bilateral hyaluronopathy to at least consider sarcoidosis, and if you have calcium. But the issue with that is that sarcoid as a cause of PE, I don't connect the two, to be honest. I don't connect the two. That would make me prioritize a malignancy. And then finally, back to what Robbie was saying with like granulomatous processes beyond sarcoid, it's your TB, it's your histo. And the only cancer that causes granulomatous increase in calcium is lymphoma. But so yeah, that's where I think a lot of things is making me worried about cancer, whether it's a solid malignancy or if it's a liquid malignancy. Mike, to my younger but smarter and wiser and better spoken brother.
I disagree with all those sentiments, but I would advise all of you never to disagree with Prof. Rez. He's always right. And Prof. Rez, I think it's, isn't it crazy how much wiser we are now in this aliquot after before compared to the previous aliquot? And I think it's really just that exercise. If you layer on inflammation with thrombosis, and you ask yourself, wait, infection plus thrombosis? You'd have to work really hard to come up with a list, right? Just go by reflex. Autoimmune plus thrombosis equals APLS associated with lupus, or nephrotic syndrome and all the other things that can cause nephrotic syndrome, which are often autoimmune. But then cancer and thrombosis, you don't have to think, you know? So I think it is just being authentic in the moment, in the face of an isolated syndrome with thrombosis, you don't have to think. And that's what Prof. Rez is teaching us. Thrombosis, don't think, start treatment and wait for things to declare. But in the face of a thrombosis and a systemic syndrome, the probability of cancer skyrockets. And so I think the analysis now, Prof. Rez, is what is this cancer? And I think I love how practical you're being about it. In real life, I think the ability of PET scan now to share the fingerprint of this disease process is so powerful and so important. And so I do agree with you that that's going to be such an illuminating test if we are able to get it. And my mind is now spending time trying to sort of mop up the things that it initially was just tagging. And I was tagging the hypoxemia and curious what the explanation was, and tagging the low platelets and curious what the explanation is. And we'll just update those analyses with the data that we have that this case is screaming cancer. And so if we just go back to the hypoxemia and say, hey, we've got some ground glass opacities and a pulmonary embolism, do those explain this degree of hypoxemia? And I think the answer is possibly, but it would be a stretch. Remember how we grade the hemodynamic significance of a pulmonary embolism from low risk, intermediate risk to high risk. And I will tell you the brief version of it, it has nothing to do with oxygenation. And that is an insight to you all about how rare it is to get marked hypoxemia in a patient with pulmonary embolism. So it takes a little bit of creative thinking to connect hypoxemia and pulmonary embolism. And the simple answer in an older adult is she has a PFO that has opened up. However, in the face of malignancy, you then have to get a little creative and wonder, does she have macro thromboses in her pulmonary circulation? And does she have micro thromboses in her pulmonary circulation? And the ground glass opacities that we are seeing isn't actually blood, pus. It's cells, i.e. malignant cells that are infiltrating the lung, causing much more pulmonary dysfunction than we might appreciate. So this complex of marked hypoxemia in a patient with pulmonary embolism in the context of cancer triggers the thought of the possibility of a very rare diagnosis of pulmonary tumor thrombotic microangiopathy, where tumor cells infiltrate and go into the lung circulation. And that hypothesis is strongly reinforced by the presence of a DIC panel. So what are we doing now with the platelets? I think with that degree of an elevated D-dimer in the context of thrombocytopenia and an escalating momentum towards a history of cancer, I think we start to worry about the possibility that this patient has cancer-related disseminated intravascular coagulation. And if you know anything about DIC, at least when I learned it, I always associated DIC with an explosive boom presentation. And that's correct, except that's only when we see it in the context of infections. This tempo of disease is classic with cancer-associated disseminated intravascular coagulation, where it progresses in a subacute manner. And so all that it's doing for me, Prof. Rez, is it's making me realize that in a patient with just lymphadenopathy, the thought to jump to lymphoma or Castleman's is tempered by the fact that most of the time when you have cancer-associated DIC, it's a solid tumor. So I'm really vigilant to the possibility that the lymphadenopathy is not the origin of the disease, but it may be a metastatic site. And I think that'll be really, really key to scrutinize that hypothesis when we get more and more imaging. Yeah, this case is really, really intriguing and a setup for a diagnostic error, I think. And so you have to be very, very attentive to the next steps. Prof. Rez, I've talked a lot. I'm really curious if there's anything else you've noticed or want to layer on before we get that next round of data.
I love the fact that you brought up the possibility of like micro, macro tumor going into the vessels. Question for you, like we actually had a case just that morning report of pulmonary tumor thrombotic microangiopathy. In that patient, and what I learned was that the majority of them are diagnosed post-mortem, 90%. Like it's very difficult to make that ante-mortem diagnosis. Also, I learned that it's most commonly associated with gastric cancer. So if like the CT doesn't show anything, considering that. But then something else that I learned for the illness script is when you have like acute pulmonary hypertension, like if you have acute pulmonary hypertension in the context of cancer with right-sided failure, then that's like a very strong signal for PTTM. Does it decrease the post-test for you, Robbie, with like the illness script you have that the RV is totally normal? And then you have other explanations for the high D dimer just being the PE itself.
Yeah, Prof. Rez, I'm struggling with that, honestly, because, you know, when you just look back at the story is very pulmonary hypertension-y. This patient has progressive chest pain on exertion with syncope and presyncope. And if you cover the echo and look at the EKG is screaming pulmonary hypertension. There's right bundle branch block. There's a negative strong negative signal in lead 1. There's an S wave in lead 1, which is a left-sided lead. And there's a Q wave in lead 3. All those are saying there's a lot of pulmonary strain. And so in the setting of a pretest probability that's influenced by the story and influenced by the EKG, and knowing how tricky echoes can be, I don't think we can toss, if the story wasn't suggestive and the EKG wasn't suggestive, gone. God, I think
I'm right. That's such a great point. Thank you. I'm right there with you. Which would be really bad news for this patient if that were the case. But isn't the prognosis on the order of months for PTTM?
100%. Yeah, 100%. I just say, like, you know, that's just a thought, and it's a thought of interest and curiosity. I think the only practical implications of that thought are, guys, when we say lymphadenopathy, you say lymphoma, right? And that was many of our cases recently. We've had Castleman's, we've had lymphoma. But I think that would be the thing to not do, is to be open to solid tumor. I'm not locked into pulmonary tumor thrombotic microangiopathy. I don't think anybody can be. Clearly, it's a postmortem diagnosis. But just like you said, if the PET CT is negative, EGD. If the PET CT is negative, mammography for breast cancer. Those are the things that I think might change in real life, you know? All right, y'all. Excited to hear your next aliquot.
That was a very detailed and informative discussion. Thank you for that. So the next set of investigations that we got SPEP, which showed elevated kappa chains 3.68 and elevated lambda 3.17 with a ratio of 1.16. Further anemia workup, haptoglobin was normal 122. LDH was elevated 407. And the peripheral blood smear showed atypical immature mononuclear cells. We did get a uric acid, which was 9.8, and CT abdomen and pelvis. I do have images if we can pull those up, but I'll read out the report. It did show ill-defined soft tissue density in the left renal pelvis, which was extending along the course of the left ureter and retroperitoneum, and then extending up to the aortic bifurcation, continuing along to the right common and external iliac vessels. So it was quite extensive. and a relatively well-defined mass along the right external iliac chain measuring about 6 to 4 centimeters. And along with this, she had a sclerotic lesions in the left 8th rib. So this is all from her CT abdomen and pelvis. Following this, we heard back from the pathology lab that the flow cytometry on her peripheral blood smear showed monoclonal B cell population. And I'm going to pause here because the next set of information would reveal the diagnosis.
All right. I want to hear some math.
Oh, no, man. I talk so much.
No, go.
No. I'll just start off real quick. Maybe I can analyze the CT and then pass the mic to you about the blood smear and the flow. Yeah, I think that the CT and the abdomen pelvis is so illuminating because it, I think, sets you up to see that everything in the chest is potentially a consequence of an asymmetric lesion in the abdomen and pelvis. And whenever you hear something that's coursing along the left ureter, you immediately wonder whether this person has urothelial carcinoma or transitional cell carcinoma, which is a very hypercoagulable, can be very devastating condition. The momentum for that hypothesis is tempered by the flow cytometry and the monoclonal population. And I think that's the tension in this case now. But what progress have we made, Prof. Rez? I think the case for cancer just got confirmed. And now it's a question of, is this a liquid tumor, a solid tumor, both? Like, how does the dust settle? And I think I'm excited to hear how you're putting it together. How does the dust settle?
Dude, Jazz, if we take a couple of his phrases, they can be like the title of any case. So Robbie, for me, I think that first of all, like just looking at this kappa lambda, it's not surprising that the kappa is greater than the lambda in context of kidney injury because the kidney clears the kappa light chain. So you can ignore that. This is not light chain disease. The LDH being elevated tells you there's cell turnover. You have to be cautious because if people have PE and pulmonary infarction, they can have a high LDH, but there's no evidence of pulmonary infarction. And there's no evidence of hemolysis because the haptoglobin was normal, and that's the most sensitive test for hemolysis. So we know that we're dealing with some kind of cancer, and everything that Robbie had said, we're making a strong signal for cancer. Usually when you have an elevated LDH, it prioritizes a lymphoma over a solid cancer. Just go look at Robbie's LDH pyramid. But you can have aggressive solid cancers that have cell turnover and cause a high LDH. But when you do a peripheral flow and you have a monoclonal population, I would think, Robbie, not interpreting these always, is that you have a lymphoproliferative disorder. Because the peripheral flow is not that great at B cell disorders. It's much better at T cells. So oftentimes the peripheral flow is negative, and then you actually have to sample the tissue, get like an excisional lymph node biopsy to get an answer. So I think with the monoclonal population, I'm favoring a B cell lymphoma, and I'm favoring a diffuse large B cell lymphoma. And then I have to ask the question, is everything else consistent with that? I mean, lymphoma can cause sclerotic bone lesions. Lymphoma can potentially lead to mass-like structures through infiltration and invasion. But maybe I can just briefly pass it back to Robbie to see. I don't know, Robbie, what do you think? I would say, like, for me, lymphoma, particularly an aggressive non-T cell diffuse large B cell, is I just put a lot of words together to try to sound smart. None of that makes any sense, but what do you think?
Yeah, I completely agree with you, Prof. Rez. I think whenever you hear a monoclonal population of B cells, you have to think lymphoma in a case like this. And I'm really curious how the dust settles. I can easily see that, the patient having two, I think, well, I should just outline. The tension is, well, what does it mean for the ureteral lesion? Because the reflex association you should have for the ureteral lesion and the adjacent lymphadenopathy is that is a solid tumor of GU origin. The reflex association you should have when you see this monoclonal population is this lymphoma. So I think in older adults, we should be open to the patient having two synchronous tumors. That's very possible. But it's also very well described that a patient with a lymphoid malignancy infiltrates solid organs. In fact, lymphoid malignancies can originate in solid organs, and there's a name for that. Those are called extranodal lymphomas. And an example I just heard about yesterday, a case, is a patient with a primary CNS lymphoma. There's no lymphoid tissue there, right? So this could be the lymphoma infiltrating the ureter, or we essentially have what is the flow cytometry equivalent of MGUS, that this patient has a solid tumor, and that solid tumor is causing devastation, and that this monoclonal population is a small population akin to those that are secreting a monoclonal protein. And so I don't know how an expert would resolve this tension. Like, I don't have confidence. I think I can guess biopsy this, biopsy that, but in real life, I would have by far exceeded my limits to be the primary. Up until now, I think we could have steered this ship and waited for input. We would have benefited from it for sure. But this is the moment where I think you just have to recognize that this case is, for me at least, my level of training does not allow me to give the patient the best possible care right now. So I would really be learning more so.
You know what's crazy? Like in my experience, Robbie, I think that like I always associate solid cancers more so with PEs than liquid, but I think that might be because I just see solid cancers much more. It's probably a known phenomenon, I bet. You agree with that?
I don't know. That's a really, really good question. I don't know. I'm gonna try to, like, I think that the learning in this case is how we can learn about PEs and what they can tell us. And also, I'm really excited to learn how this tension was resolved of which cancer, or are there multiple? Enlighten us, please.
Sure. So following this, we were figuring out what to biopsy in her, and she did have a left axillary lymph node about 1.5 centimeters. So we did biopsy that, and the lymph node showed mantle cell lymphoma with Ki-67 of 35%. And we also involved hematology, who did bone marrow biopsy. And the bone marrow biopsy also confirmed mantle cell lymphoma involving 60 to 70% of marrow cellularity, with the Ki-67 score of 10 to 20%. So the final diagnosis for our case is stage 4 mantle cell lymphoma, and she's currently being treated with our mini-CHOP. So we did have a lot of teaching points from the case, but there are a few we would like to share, but I'd pause here for you to comment on the diagnosis.
Oh my gosh, I really just want to learn from you guys. This is an educational case. I'll pass the mic to you to enlighten us.
So for us, I think just a few things starting from the history itself. We realized that the presentation with pre-syncope and syncope, it's like, I didn't know this, Dr. Bajwa actually taught us this. So I didn't know that a PE could have these symptoms. So that is one thing we learned, that even a PE in like 1 in 10 cases can present with pre-syncope or syncope. The other thing was tachycardia is supposed to be observed in a PE, especially like with such extensive PE, but she did not have any. So that's another thing to keep in mind, and especially in patients who are older or on beta blockers. Then I know we already talked about the risk stratification in pulmonary embolism, and I would like to pass the mic to Dr. Bajwa to elaborate on mantle cell lymphoma.
Preeti, we're on VMR. You can call me Jazz Deep or Jazz now. So respectful. So yeah, this was like a wonderful case, especially considering when we saw this patient, the comment was PE was on heparin drip, but it was very odd for me to exclude that thrombocytopenia. And I was very suspicious for some type of cancerous process, especially when we got more history from her, which prompted us send the peripheral flow cytometry, which for majority of the cases is never fruitful. It doesn't help us. But in this case, when we saw that we got HEMONC on board and then the CT scan, we got that right away, and it showed that massive finding. So basically, this was a learning point for me as well. Is like, I've never seen mantle cell lymphoma in the clinical setting. I've only read about it in medical school. And I remember reading about it. It's just supposed to be a very indolent disease. However, that's not always the case. So it's a rare B-cell lymphoma, which comprises about 5% of all non-Hodgkin's lymphoma. Interestingly, it is more common in men in a 3-to-1 ratio. And the median age is 60 to 70s, and Our Lady was 88. So, and mantle cell lymphoma remains a largely incurable disease. And there's something called the MIPI, or Mantle Cell Lymphoma International Prognostic Index, which is a scoring system to stratify patients with mantle cell lymphoma. And the scoring system basically uses age, performance status, LDH, and elevated white blood cell count. And based off her, except for the age, everything else, like it was favorable. She did not have an elevated white count. Her LDH wasn't terrible, and she was a very high functional 88-year-old female. So, and then they also mantle cell lymphoma also has shared features of both indolent, the incurable nature, and aggressive, so aggressive clinical phenotype. So it can have both features. And basically, because there's no curative standard treatment established for mantle cell lymphoma, they use this scoring system in addition to the aggressiveness of the disease to see if treatment is warranted. And I just chart reviewed her not too long ago. She's doing well on R-CHOP and have improved significantly. That was the end of our teaching points.
Oh my gosh, no, this is the thing. I never seen Robbie so silent for so long. But Jazz, that's really helpful. Thank you for not presenting today because it gave us a shot at the final diagnosis. Kriti and Ali, thank you for your excellent presentation and reflections on the case. And Robbie, any words to share before we pass the mic to Ethan for the teaching points? Ethan, you're up. It's rare. Robbie has gone 1 minute, guys. Keep the timer going.
Okay, thank you, Jazz and Ellie and Kriti for the amazing case and amazing discussion from Rabi and Reza. This is a really amazing case, very complex. So this is a patient, 88-year-old female patient presented with chest tightness and hypoxemia. And in a patient with hypoxemia, we prioritize cardiopulmonary causes. And we seek clues in the physical examinations, for example, JVD, abnormal breathing sounds, additional heart sounds, etc. And here the patient had weight loss, which is atypical for heart failures. So we have to consider that. And then another atypical features is the presyncope or syncope. Because in CAD patients usually are hypertensive, and possible explanation for this is either a underlying different systemic disease or a very severe triple vessel disease causing hypotensions. And then Ali give us the rich past medical histories, which for in real life we have to. It would be wiser to connect the presentation with her past medical history, for example, to connect the presyncope with her carotid stenosis and AV block causing a congested heart failures. And weight loss could be non-specific and explained by COPD-induced thoracic dysfunction and cause cachexia. And with the patient's hypoxemia resistant to O2 supplementation, we have to consider a shunt physiology like PEs or other etiologies. And then in labs, we see hypercalcemias and abnormalities in the hemograms. And hypercalcemia here could be noise or signals, and it could be explained by hydrochlorothiazides and vitamin D supplements. But if we're considering as a signal, the most common inpatient causes are malignancies and granulomatous diseases. And with the anemias and thrombocytopenias, the anemia was mild, and with disproportionately thrombocytopenia, we have to consider the causes of isolated thrombocytopenia to make progress. And that includes infections causing thrombocytopenias in like malaria or antibodies against plated membranes like HIT or ITPs, or environmental causes like MAHA or splenomegaly. And then we found that the patient has pulmonary embolisms. And in patients with pulmonary embolism, we have to stratify them with risk. With the high-risk patients, they were hypotensive and they are hemodynamically unstable. And in patients with intermediate risk, the patients will have RV strains and abnormal biomarkers like abnormal BNPs. And in low-risk patients, they will have normal RV functions and normal biologic markers. And then we found in the imaging that the patient also has lymphadenopathies. And consider that with the clues that was provided in the previous aliquots, we have to consider an etiology that caused the lymphadenopathy and a hypercoagulable state causing the PEs. And with the age and other clues, we have to prioritize a malignancies. And then with the presentation of DIC in the labs and GGO in the imagings, and in the GGO, we have to think about blood, pus, water, and cells. And then a hypoxemia not compatible with the risk stratification of PE in this patient. And in this patient, the RV is normal, no RV strain here. We have to consider a rare possibilities of tumor thrombotic microangiopathies. And then with a high LDH, we have to consider hematologic malignancy over solid cancer. And then finally, through lymph node biopsy, we found out that the patient had a mantle cell lymphoma. Yeah, the case is so complex, and thank you so much for this case, and I really learned a lot. Yeah.
And just to make note for Prof. Reza, I was silent for 4.5 minutes, which is probably a record. But I have to break the silence to give a shout out to Ethan. It was absolutely amazing teaching, Ethan. It was so cool to see you absorb all of it. But honestly, my favorite part was how you narrated the whole story from beginning to end and peppered it with teaching points along the way, like reliving the journey from beginning to end. It was really, really well done. All right, Prof. Rez, that ends my babbling. Thank you all for hanging out, and big shout out to Jass's 2 mentees. We're very, very grateful to you guys, Ali and Kita, and hope you, Akriti, and hope to see you all on Sunday for VMR. Bye.
Thank you so much for having us. I learned a lot today. Thank you.
Coming.